Welcome, everyone. My name is Prem Kaur, and I'm the President and Chief Executive Officer of Cavernous Malformation Canada. We're absolutely thrilled to have you here for our webinar, How Do I Deal with My Headaches and Seizures as Someone Living with Cavernomas, delivered by our speaker, Dr. Atif Zafar. Now, before I introduce Dr. Zafar, let's take a moment to highlight some key points for our time together today. For your awareness, this webinar is going to be recorded and will be available for viewing at a later date. We're going to have some time for questions. And for those of you in attendance today, if you look at the bottom of your screen, you will see a box that says Q&A. This is the place for putting in your questions that you'd like to put forward for this session. When you do put questions in, please keep in mind that they should be general, and to protect your privacy, please do not include any personal information that is medical in nature or about yourself. Also, as we're including information-based questions, it's not a forum for personal medical advice, so please keep that in mind as well when posing a question. We'll do our best to have as many questions answered that we can during our time together. Also, please do not use the chat window for posing your questions, as it's not being monitored during this session. And now I'd like to introduce our guest speaker to you. I'm really, really excited to announce him. And Dr. Zafar obtained his Bachelor of Medicine, Bachelor of Surgery from Dow Medical College, and completed his residency at the University of Iowa Hospital and Clinics. He also completed a vascular neurology fellowship at the Cleveland Clinic. Upon completing his fellowship, Dr. Zafar became an assistant professor of stroke and vascular neurology at the University of New Mexico and School of Medicine, and then moved to the position of chief of the stroke program at the University of New Mexico School of Medicine. Presently, Dr. Zafar is an assistant professor of medicine, Division of Neurology at the University of Toronto. Additionally, he is co-director of the fellowship program Stroke at St. Michael's Hospital and medical director of St. Michael's Hospital Comprehensive Stroke Program. Dr. Zafar is the chair of our Clinical and Scientific Advisory Board, that being Cavernous Malformation Canada. His clinical focus is on complex stroke cases and cerebrovascular diseases. Dr. Zafar's academic pursuits include a personalized stroke algorithm, equitable care access, and patient-centered care development. And with that, I will hand it over to Dr. Zafar.
Thank you, Prem. It's been a pleasure and an honor to be here. I've done similar webinars before, I think, with Prem and back in the US as well. So just as part of the introduction, I want to let you know that a lot of the information I'll be sharing with you here is obviously, I want to have a disclaimer that cavernous malformation, as you all know, is a rare, syndrome or a disease or whatever we call it. But a lot of you living with it know that there's uh, limited data, right? There's not a lot of data, but there's a small group of experts, some of my mentors who have been doing a lot of research the last many years. And so the information that I'll be sharing will be based on a lot of those research and publications, some of which I was part of along, with my mentors. I also want to mention, one of my mentors, Dr. Leslie Morrison. She's kind of the pioneer in the cavernoma world. A lot of the research and the projects I ended up pursuing where I took over from her when she retired. And a lot of our learning literally is based from our patients. And that's why I really enjoy having these type of engagement sessions and interactions where we can add some value in your life, but more importantly, we learn from you. So as you share your symptoms and your comments, it allows us to learn on how our patients are doing. So I'm really looking forward to this talk. Hopefully I'll wrap it up in 20 minutes. Again, as we move forward, a couple things I want to share is I don't have any financial disclosures really. This is something that the cavernomas, HHT, some rare complex neurological or neurovascular syndromes are my interest. I'm a student of complex neurological syndromes, so a lot of this information is based on some of my anecdotal and research-based experiences. Uh, The way I've kind of compiled this talk was obviously focused on you. So Pram was kind enough to share some of the discussions that happen on the forum, and the discussions that questions that you have asked of her. So I've tried to capture a lot of those points, but some of them will be missed, and that's why at the end we'll have an interactive question and answer session. All right. So with that, maybe we can move on. Uh, so again, cavernoma, as you're living with it, many of you or your family members are living with it, it's uh, a complex syndrome. There are a lot of different things we deal with when we're living with it. The two topics we're going to cover today are headaches and seizures, most common experiences among our patients. Okay, so I'll go through these. I haven't made these slides very busy, but I'm going to be sharing some hopefully useful content for you. So let's start with understanding CCM. I don't want to spend too much time on it, but as you know, these are abnormal capillaries. A lot of times, whether through sporadic genetic mutation or familial, meaning running in the family, those mutations make some of the capillaries abnormal in the brain. And then sometimes those abnormal capillaries, the bunch of abnormal capillaries can misbehave every now and then in the form of triggering headaches, causing seizures, and sometimes causing oozing or hemorrhage in worst case scenarios. Uh, Patients can have one isolated cavernoma, or people can have multiple cavernomas. And a lot of times, based on our research, we figured out that many of our patient population, when we were doing random screening of MRIs on them, many patients didn't even know they had a cavernoma. But when we did the MRI, we found that they had dozens of them. While on the other hand, there were patients who had only one isolated cavernoma, but it was bothering them to the point that their lifestyle and their entire overall life was affected by it. So that's why I wanted to spend some time on understanding the cavernoma, because it would help you answer some of the questions you may have. Now, some of the topics that I heard, that get brought up is the role of blood pressure. And high blood pressure, obviously something you hear about, that we recommend keeping the blood pressure in a good range. But sometimes you ask whether low blood pressure can be harmful, or is it beneficial? Now, I would say that there's no large scale study done to answer this question, but we've had cavernoma patients over the last many years admitted in our ICU. So we have had anecdotal experiential learning on how patients do as the blood pressure changes. And there are two really, background information that helps answer this question. Simply put, the low blood pressure does not harm the cavernoma behavior. So that's kind of clearly something that we have learned. And where do we come, how do we come to this conclusion? Again, it's not, we don't have a very large pool of data to back this up. But every time we have patients with cavernomas, and if they do have a high blood pressure, they get admitted to the ICU where we control their blood pressure. Oftentimes, as we are controlling the blood pressure does drop down. Uh, and as you know, repeat imaging is just part of the screening that we do in the first few days when the patients with bleeding are admitted. And we find that the patients with cavernomas actually don't show any abnormal imaging findings or any significant changes in their clinical exam findings if their blood pressures are dropped by mistake or just because they got some extra, blood pressure medications compared to our other patients who have major hemorrhages. And as you know, hypertension is one of the most common causes of brain hemorrhage. So in those patients, if we are very aggressive with blood pressure control, we do see some side effects happen. And I think that's where this confusion may have come up, because in regular hypertensive hemorrhage patients, low blood pressure can be harmful if the blood pressure gets dropped down pretty quickly by the doctors or by the families. But in cavernoma patients, when there's oozing or hemorrhage, there's no major implications with it. Now, in the long run, I have personally some patients whose blood pressure run on the lower end for whatever reason, their body physique, their heart issues. And I've kind of tried to pay attention in them, maybe done some extra MRIs over the years just for our own anecdotal learning. And to be very frank, we haven't found any concerns around cavernomas misbehaving more, meaning oozing more, or causing issues in other ways. On a side note, if patients have chronically low blood pressure, it is possible that they can have symptoms like lightheadedness and fatigue just as a result of the low blood pressure, without any correlation or association with cavernomas. Moving on to the next questions that I felt like were raised was the vitamin K. So the vitamin K, has come up with some of my patients. They've asked this, as part of their multivitamin regimen, or, they were taking vitamin D, they read online and they felt like, okay, maybe if I take vitamin K, is it going to help? So again, there's no large pooled data to answer this question as well, and that's why I think you brought it up. But based on my personal experience and based on the limited, sub-analyses and other data that we have reviewed over the years, uh, short answer is that vitamin K is safe. Uh, there are no major issues. And anecdotally, when we have had patients who had to take vitamin K for one reason or the other, some people have, some bleeding issues going on or some other, menstruation related issues where some of my patients had to take it. And obviously we monitored them a little bit closely as we had limited data. And over the years, I haven't found any issues with patients taking vitamin K. Now, all of this information that I'll be sharing, as you know, I am less diplomatic in a way. Like whatever I know, I try to share it. But there is a disclaimer that make sure you discuss it with your personal doctors, so that for your personal case, this information is more relevant. But in general, vitamin K is safe. Okay. Sometimes it comes up that, I have a son with cavernoma, or I have a cavernoma and I like jiu-jitsu or karate, or I play American football, or I play soccer, and um, or boxing, and does trauma, can that impact me in the long run? Now, I don't know how aware are you about this, but in general, any field that's going to cause a lot of concussions or trauma will lead to dementia risk going up. So that's why a lot of boxers or American football players do end up having early onset dementias, and that's just an independent risk factor for concussion type of sports, or repeated traumas. Now, one or two car accidents or traumas here and there, that doesn't, the information I'm sharing is not relevant for that, but recurring trauma, meaning multiple injuries on your head, which led to some unconsciousness events. Uh, in those situations, we get asked whether there's a direct hit on the cavernoma. Again, the short answer is no. So there is no direct impact. So when I was in the US, I had a few young kids, between the ages of 18 to 24, who were playing football actually professionally. And obviously, initially we said no, 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 but there were some people who wanted to go ahead and still do it. They wanted to maintain high functioning, lifestyle. So what we ended up doing in those patients is we ended up doing more MRIs, just to keep an eye, or just to stay on top. And we found that there was nothing really predictable going on that would correlate with those type of sports that have higher trauma risk. So again, anecdotal, small database, experiential answer, but no major issues there either. The other question that I read was very interesting for me was, iron, anemia, any correlation in this domain for cavernoma patients. Again, the short answer is no. There is no real serious correlation there. Actually, we have, personally, I have, and some of my colleagues who take care of cavernoma patients have patients with anemia. Anemia for other reasons, patients can have heavy menses, or they can have GI bleeding issues, or a thalassemia minor, or other things going on that leads to iron deficiency, and they're on iron supplements and things like that. Um, and again, anecdotally, for our own learning, we start monitoring those patients a little bit closely, and anecdotally, we haven't seen um, anemia triggering anything significant out of the blue, or iron supplementation causing any independent issues on some of those patients. Uh, Now, The only caveat is that iron supplementation does lead to some constipation. And there are these issues that we keep on seeing in our patients where, and Dr. Khan has done some research at UPenn on the GI microbiome related changes causing some cavernoma misbehavior in his animal models. Uh, Really where I'm going at is just making sure that your GI habits are maintained. And even if you are on iron supplements, making sure that the constipation is getting treated naturally by eating more fibers and fruits should do the trick. The only other interesting part is that yes, iron deficiency anemia or any sort of anemia is going to make you feel fatigued. And a lot of cavernoma patients, especially multiple cavernoma, who have multiple cavernoma, those folks do tend to feel fatigued as well. So sometimes, obviously, it could be a double whammy, right? Then making sure that your iron supplementation or anemia is optimized as soon as possible helps prevent that. Now, some of my patients, and this question comes up, I think, in your forums as well about tinnitus. Uh, this is a tough one. I would say that a lot of our other cerebrovascular syndromes outside the cavernoma world, patients with AVMs, patients with just carotid disease, tinnitus does come up quite a bit. And it's one of those things where we don't have uh, any significant cure yet. Uh, Folks who have a cavernoma in the deep part of the brain, like in the deep temporal lobe, close to the brainstem or in the brainstem, uh, can have tinnitus as part of the disease or of the cavernoma location. Normally, I tell patients that sometimes we ask them to discuss gabapentin. Only 10 to 20% of the patients respond to it, where the severity of the tinnitus gets better. And if it's safe for you and your family doctor or your neurologist is okay, then considering that is an option. Uh, there are some new drugs that are coming out now in the market. There's some side effect issues, so we're monitoring how effective they are in regular non-cavernoma patients with tinnitus. But once more data comes out, we'll share names of those medications a little bit more as well. Uh, Now, there are some patients who have cavernomas and then they have tinnitus. So it's always good to have some workup done as part of tinnitus. For example, at our hospital, one of my colleagues in the interventional world has figured out that some venous flow. So again, capillaries are these bunch of capillaries that connect with the veins eventually. And what we have found independently that tinnitus, risk of tinnitus, incidence of tinnitus is higher in patients whose venous flow out of their brain is sluggish. So now, both in the US and in Canada and our hospital, we end up putting some stents in patients. Again, not carinoma patients, but in general, tinnitus patients can get those stents put in their brain that helps then with the tinnitus. So just letting you know that when you have it, it's good to discuss all other options, keep our minds open and ideas open. Is it possible that there's another cause of tinnitus going on independent of the cavernoma? But irrespective, cavernoma patients, based on where their cavernomas are, can have tinnitus. Quickly, I'll go through the other things. Cognitive effects. I think you already know, if patients have multiple cavernomas, if somebody has a cavernoma in the right-handed people have cavernomas in the left hemisphere, large lesion, one large lesion, multiple small lesions, we do end up seeing some cognitive impact there. So a lot of times, if you go to your local doctors or physicians, neurologists, neurosurgeons, uh, it's not a bad idea to ask, can you tell me where are my cavernomas, what part of the brain there are? And if you hear that they are multiple in your cerebral hemispheres, or they're more dominant on the left side, and you're right-handed, then this is kind of a giveaway that it makes sense why cognitive issues are being noticed, and it could be explained through that. Last part is association with sleep. Uh, every patient who's seen me, I emphasize this a lot. And whether it's with sleep apnea or without sleep apnea, we all know, and the recent studies are showing uh, that at night when we're sleeping, the lymphatic flow happens in the brain. And as you know, there are two major ways of cleaning the brain. One is through the capillaries, the other is through the lymphatics. So if you have a lot of cavernomas, then you do need some very good sleep to make sure that whatever that compensation is needed for the weak capillaries that we have, that we get a lot of these toxins out of our brain at night. So making sure that sleep is prioritized, even if it requires some lifestyle adjustments, getting rid of caffeine intake in the afternoon, uh, using melatonin, using passion flower extract, some of these benign things that we know work is safe for cavernoma patients. That would be a good idea to make sure that your sleep hygiene, sleep lifestyle, dietary things. There's a lot online about basic lifestyle changes for optimal sleep. But in my experience, it makes a huge difference. All right. So as we move forward, I'm going to cover quickly the two topics, the headaches and the seizures. And really, there's very simple stuff that would help you understand about the headaches. Number one, the lesion location plays a role in why we have headaches. We all know that 50% of the cavernoma patients, when we did all our large pool data surveys and studies, we found that 50% of the patients positive for CCM have headaches compared to 1/5 of that general population. So we know that cavernoma patients have more headaches. When we were doing these asymptomatic screening studies on familial cavernoma population, we found people didn't even know they have multiple cavernomas in their heads, but they did have some headaches that they were seeing doctors for. And then we put two and two together that yes, it increases the risk of headaches. Now, this is a weird topic because even in other brain tumors, brain lesions, many neurologists and many physicians say, oh no, it's separate. And I remember at the VA hospital system in the US, patients who had pituitary adenomas, a very different set of adenomas in the brain, they were going through the same issue in the 90s until the VA hospital there did a large pool study analysis and they found that clearly pituitary adenoma patients had higher prevalence of headaches. So this allowed the regular neurologists and the physicians to understand that we need to work with the group of patients who have more lesions in their brain in a little bit different way. I would agree that genetic wise, when I analyze some of the genetic databases out there, there's no like proximity of the migraine or headache genes to any of the three cavernoma genes. So we know that. So it's not like that the risk is genetic. It's just that if I have migraines, which I do, and then I don't sleep well and I don't eat well and I'm dehydrated or I'm stressed, I end up having more headaches, right? Similarly, if I have cavernomas that increases, changes in the brain. It triggers some changes in the brain physiologically, so it can give you a little bit of a higher risk of having headaches. So that is, well proven. I don't think there's any doubt about that. Lesion location is a kind of a controversial thing. I would say anecdotally, I feel like very deep lesions and in the posterior fossa, meaning back of the head, I've seen more correlation with headaches. But some studies, large databases showed that not really, the deep were not associated with it. Similarly, I've seen patients with larger lesions in the cortex, meaning superficial part of the brain, have more headaches as well. But here's the interesting part. If you start chasing on how your headache's behaving and trying to use it as a predictor of how the cavernoma is doing, you'll be confused all your life. It just doesn't, these two things aren't matching. So that's why anytime I have a patient with cavernoma and they have headaches, I counsel them and sometimes I beg them that they need to do much better than even regular people with headaches in how they're managing their headaches. Because if you're managing your headaches well and you don't have frequent headaches, your headaches are once every 3 months, once every 4 months, that's the right situation and position to be in. Because now in this situation, if you end up having headaches that are lasting for 2 weeks for no reason, you didn't have a cold, you didn't have a flu, you didn't have any stress going on, and you're still having headaches, that would be a reasonable time to go in and get checked, maybe get another screening exam, with your neurologist. Similarly, if you are having a headache and there are some other symptoms associated with it, that the eye is twitching more, face is drooping, arm weakness, numbness, tingling, balance is off, speech a little bit different. So headache plus one other concerning symptom, that should be an alarm for you. But otherwise, if your headache's wacky and troublesome anyways, and then 3 months later they become different. And and more complex, then it's not a predictor that there's something going on. And that's why it's so critical to work closely on your headache hygiene. Lifestyle, sleep, stress, all of those things uh, are going to cause headaches to get worse, like it does in any headache or migraine patient. The last part before I move to auras and what I think works really well, uh, that there are food items that can trigger headaches. For example, I have migraines, and I know that if I have chocolate with caramel, within 48 hours, I'm going to have a bad headache. So I like chocolate, so I end up having chocolate on weekends when I'm off because I know a couple days later. Now, before I became a neurologist, I didn't know this. I was just, the migraine was bothering me a lot. But now I know that I can identify triggers. Uh, my daughter, she's 9 years old. She has bad migraines as well. And similarly, I started doing this analysis, and I found that when she has caramel, not with chocolate, but when she has caramel, she has it as well. So there are certain things, some people with red wine, some people with uh, pepperoni, processed food. You just have to identify that. But that's a big key factor that I would love Cavernoma patients to focus on so that your headaches are better controlled. Moving on to the auras, that's like a very interesting domain. Uh, so auras is this magical phenomena, that you experience, right? Some people feel these flashes of light. Some people feel like that they feel a little bit crankier than usual, a little bit more tired, and they can tell that today I'm going to have a headache. That's really what the auras of headaches typically could be like. When we talk about the seizures, you'll hear some other auras from me. So that's why I'm emphasizing that the typical migraine auras are these two. Very rarely, if you have a hemiplegic or complex migraine on top of cavernoma, then you can have the numbness, tingling type of symptoms as auras for migraines. But otherwise, visual auras and that feeling that I'm more cranky and slow and I'm going to have a headache, these are the only two common auras that we see in cavernoma patients with headaches. The last part about the treatment. Now, propranolol, nortriptyline are the two commonly used migraine and headache preventive medications in cavernoma patients. They've been well studied. Most of the time, they're safe. So if your physician, your family doctor, or your neurologist is confused, you can bring it up, these two names, and see if they're open to working with you as a preventive. So these are preventive. The third preventive that I had a chance to work with some of my patients back in the US, and some have done it here, are the CGRP, both Botox or CGRP inhibitors. These are Aimovig type of medications. So we've tried and seen anecdotally, and patients have done reasonably well for headache management. These are very expensive drugs. So that's why they're used as second or third line, or unless you have insurance that supplementally covers it. For abortive, there's this drug called Ubrelvy. Again, expensive. So ideally, if you have supplemental insurance, then it helps. Or if you're on disability, it helps. But that's kind of a safe abortive therapy to kind of consider or discuss with your physicians or neurologist. Uh, Tylenol obviously is the first line we all know about. You guys are told that don't do NSAIDs enough. So Tylenol is pretty much what we have when we are having a bad headache as an abortive. So that's why I thought I would share the Ubrelvy, something I've tried now with at least 3, 4 dozen patients with the diagnosis of cavernoma. Some, I'm working very closely with, and we found no issues there. Back in the US, I had a series of patients uh, with cavernoma who we consented and then went ahead and did Botox on them because their headaches were not responding to simple medications like nortriptyline or propranolol. And we found that they didn't have any major issues, most of them. But again, now with the CGRP blockers there, it's better to stay away from Botox and go towards these. Just because Botox has these other side effects with the eye droops and things like that as a side effect from the injection. All right. Uh, all right. Recognizing the headache triggers, I already kind of touched upon them. Sleep deprivation, stress, food items, some of them I mentioned already. Uh, Stress is a big one, I would say, and then sleep apnea. If it's untreated in cavernoma patients, I've seen a lot of times it would end up causing daily headaches. So something to look into. If you're snoring at night, then discuss with the family doctor. Bleeding is a trigger as well, and that's why it's so important that with all the other things that can also trigger headaches, we maintain a very good headache lifestyle that can minimize our headache frequency and severity so that if the headache does come back and is triggered, then we know that's not a chocolate or it's not my stress, it's not other things, rather the lesion. So then if especially it's associated with any other symptom, then going ahead with the for closer monitoring with your physicians is ideal. I touched already upon it, the management part, lifestyle, and the medications that we talked about. All right, so that's the last part of our talk. So seizures uh, in CCM. Now, quite a few studies have been done. One that a large group did. I was a part of it. It's going to be published. Is going to be published, I think, uh, in the next couple of weeks. Uh, the data shows that anywhere from 10 to 30% of the patients with cavernomas can have seizures. So that's a pretty decent number. Typically in general population, it's about 1%. So the incidence and the prevalence of seizures can be high. It's all based on the location typically. One question that repeatedly comes up is if I have a lesion in my brainstem and then can I expect having seizures from that? The simple answer is no. Brainstem lesions do not cause seizures. A lot of the times when brainstem lesions, as you know, have high risk of oozing or bleeding just because of their location, patients can end up having some tightening, jerky movements. So when they're having it in front of their physicians or in the hospital, when confusion comes up is they're diagnosed as seizures, but in essence, it's just those spastic movements that occur as part of the brainstem, semiology, but those are not seizures. So there are no case reports of brainstem cavernomas causing seizures. Now, if you're speaking with your neurologist or neurosurgeon and you're hearing that you have lesions in temporal lobes, either on the right side or the left side, and then you're having some mysterious symptoms, and those could be anything from having a deja vu feeling for 30 seconds to feeling like there's a tire burning or rubber burning in the room for 15 seconds, or a feeling like something's kind of rising up your belly again for 15, 20 seconds. So I'm mentioning the second part because seizures typically are very short lasting. And that's how we distinguish them as neurologists from many other auras and many other pathologies that exist. Seizures are rarely more than 1 minute long. And yes, we normally hear about seizures that those are convulsions, shaking, but in cavernoma patients, seizures can be as simple as staring into space for 30 seconds and then their relatives or friends trying to snap them out of it, but they couldn't because they're just so out of it. If I'm cognitively slow and I stare into space and some of my colleague shakes me, I will come out of it, right? But in those 15, 30 seconds, if you're in the seizing moment, and these are minor seizures, a lot of times I feel like they get undiagnosed because they're not bothering you in any other ways. You're still watching TV, you just snap in and out in 10, 15 seconds. Uh, but if you have lesions in the temporal lobe, then and you're noticing these type of occasional events that are very short lasting, then something to document in your diaries so that when you go to your doctors, you can bring it up with them. The three things that I discussed, the deja vu, the gastric uprising, meaning this feeling that something's coming up my belly, and the burning kind of a rubber feeling, that's something we train our students and residents and fellows about, that always ask patients with brain lesions about this. So just letting you know that this is something that can be associated with minor seizures, and even if you have it and it's not getting treated, it's not the end of the world, thankfully, because it's not life-threatening or dangerous. But obviously, it's better to get it diagnosed so that you're on the right treatment with your doctors and then you don't end up having these experiences that can be somehow disruptive, right? The other part is the recurrence risk. So some of my patients had seizures. We started them on treatment. 2 years went by. They had no more events. Who likes to be on medication? So they ask, can I get rid of it? And my answer typically to them is that if they do have active lesions, meaning some significant size lesion, then I tell them that your risk of recurrence is high. And studies have shown anywhere from 30% to as high as 60% recurrence rate of seizures. So that's reasonably high. Now, if anybody has had surgery, the lesion has been taken out, and now you've been 1.5 to 2 years seizure free, different ballgame. You can taper down. But otherwise, lesional seizures, it's better to stay on it if you had epilepsy or seizures for a long time rather than fighting to get rid of the medicines because the recurrence rate is high. Now, the auras I already talked about, these three auras, these are the more common ones, but it could be others based on where the lesion is. The most relevant thing I wanted to talk about is the medication. Now, when you're going and speaking with your neurologist and you feel like that, you're in a limbo and the seizures keep on happening, they're trying their best, and you feel stuck, some minor seizures are still happening, then in our experience, a combination of Keppra and lacosamide works really well. And I've tried this for the last 10 years on the most complicated patients. Uh, some of them who are in the emergency room every second day for these seizure issues. And we have seen drastic improvement in their lifestyle. I remember one of my patient wanted to get into med school, very high functioning young kid, but these seizures were like slowing him down. And eventually, we started him on these two, and it really helped out to decrease the seizure frequency and severity. So Keppra, Vimpat, meaning lacosamide, are two medicines that's worth a discussion if you're struggling with your doctors and your doctors are struggling in your community to bring it up if you haven't tried that. Cost-wise, the lacosamide can be a challenge. In those patients, we have seen valproic acid do a reasonable job, and that's very cost-friendly along with Keppra in patients who have who can't afford it because lacosamide is an expensive drug. The last part is aura versus seizures. Uh, so I already told you very clearly that these three are the common auras, and there could be other auras, but typically the visual auras are not very common as seizure auras. They're more commonly associated with headache auras. All right. Uh, and then, I just want to emphasize one thing, that seizures that we train our medical students and residents and fellows is seizures are stereotypical. They don't change. So if you have something for 15 seconds and every 1 month or every 3 weeks, you're experiencing that little 15-second spell, that's when I would worry about seizures. Otherwise, I have a large panel of patients that I take care of. I would say that majority of them, I'm not dealing with seizures. But when I am dealing with patients with cavernomas who have seizures, it can be challenging and then you need to work with them on those medicines. But I don't want you to, after this webinar, kind of freak out that, oh, all these little spells could be seizures. They're stereotypical, they're short lasting. Typically, if they're getting missed, they're not going to be life-threatening. Yes, they can slow you down a little bit, but typically, based on our studies, we haven't seen that even if they get misdiagnosed for a year, 2 years, 3 years, that it causes any lifelong implications in a very negative way. So that's at least a little bit reassuring. I already discussed with you the treatment options. Again, as a disclaimer, I do share a lot of this relevant information because I feel like some of my patients where I'm doing very little stuff that I have seen and managed for a long time, like leveraging Keppra and Vimpat as a combination, and then it's making, like significant impact in their lifestyle. So that's why I bring it up that just bringing these medications name with your local physicians can sometimes help optimize things at the local community level. And that's all I have. Thank you so much for listening to me.
Well, thank you so much. It was incredibly informative and hopefully might have brought up some more questions, but we will see. So I do have somebody who has asked, What is the most natural treatment of headaches? And this person shares that they use peppermint, which is fairly good.
So, Prem, what's the question? Are they asking, is it safe? Or
Well, they're asking what is the most natural treatment of headaches? And
I
they
get
also
it.
shared that they particularly use peppermint that's working fairly good. But is there any other natural treatment of headaches that you're aware
You
of?
know, I won't lie, like in med school in our training, we don't really get alternative medicine kind of, studies as such, but it's is an area of my interest because again, I learn a lot from my patients and our patients are giving us these ideas. Like one of my patient with Cavernoma said that they were using turmeric every morning. And that was helping them with their headaches. The peppermint spray is one example. Uh, I have some patients who have responded to a little bit of pure cannabis, right? Oil that they've used. So there are these things, in Cavernoma patients, we have heard melatonin, interestingly, can help with headaches, irrespective of its sleep benefits. Uh, so there are these natural ingredients. I normally feel like I had some, because of my natural inclination, there were some natural herbs that I heard from my patients that they were working. Some like Chinese herbs, some like, South Asian herbs. And I had a friend in Boston, and I asked him to kind of get some of these drugs checked. I just was curious and like what uh, is in there. And after he did the analysis and gave me, a very clean chit that everything's good, there's no toxin, there's nothing. Since then, I've like started to tell patients that if natural herbs or those natural ingredients are helping you, uh, it should be fine. But I already mentioned, the turmeric I've heard repeatedly uh, from patients as well. Melatonin I've heard. These are some that I've heard of.
Okay, great. Thank you so much for sharing that. That's helpful because I think that people are always like looking for something they can turn to, you know. Another question we have is, and actually I've heard this from a few people, is can head positioning for people who have cavernomas, head positioning, whether they suddenly dip down, like maybe they're doing downward dog in yoga, or, they quickly turn their head, and that brings on some symptoms, even if they're transient symptoms. Have you heard much about that? Is that common thing with cavernoma and to symptoms like dizziness or a little bit of lightheadedness feeling? Any thoughts on that?
Yeah, I agree. This is something that patients experience. And the reason I think you brought it up is there's this gap between the experience that our patients have and what the data that we have in our neuroscience research. The data hasn't really confirmed any correlation, unfortunately.
Yeah.
But I will tell you, because I do take care of some other complex neurological patients, I personally am very confident that anybody with lesions or where the blood flow is sluggish or there's mixing of blood going on, like in other syndromes like HHT, this is a commonly kind of discussed problem amongst my patients.
Okay.
So I would say that there is probably something that the healthcare is not hasn't picked up on it. Uh, Now, can it be a sign of something dangerous brewing in?
Hmm.
Anecdotally, for my own learning, I've like kind of, tried to analyze it and I found the answer to be no. So it's kind
Okay.
of a rather benign thing, even though it can be disabling and disorienting for our patients.
Yeah.
But thankfully, we haven't found this to be a danger sign as such. The last part about it is that some patients who can have cavernomas may also have some other issues going on. For example, when you have headaches that get worse with you laying down or standing up,
Okay.
not just with positional,
Hmm.
shakiness, but consistently that you have to use more pillows now and things like that, then that is a very different type of headache that you need to really bring it up in a different way. That when I lay down, my headaches get worse. When I sit up, my headaches get worse to the point that I'm now sitting on a couch. So that's a different type of a disease or pathology that needs to be diagnosed as a separate entity, and it has really good treatment available.
Okay. Okay. Awesome. That's good. And it's also helpful for people to know whether those kind of movements and the symptoms are like an urgent sign of something too, as well. Um, and also, a question is frequent sharp eye pain, a result of having a cavernous malformation?
Again, the evidence-based answer would be we don't know. Uh, Personally, I would say that there are specific areas where if the lesion is located like close to the optic nerve, in the brain, uh, then there are, anecdotally, I've seen patients with this where I had them sent to neuro-ophthalmology, and sometimes just optimizing their vision through prism glasses and stuff helped, and the eye pain was not necessarily truly a lesional pain. It was they needed a separate type of eyeglasses because of the lesion causing changes in the optic nerve. So anecdotally, I had a few patients where we experienced this. More commonly, though, these symptoms are a part of their headaches not being ideally treated. So I've seen that in patients with cavernoma when we're not managing our headaches appropriately, thinking we're fighting it, we're strong, we're going to live with it and fight it through. Uh, the headaches start misbehaving in different mysterious ways. And
Oh,
that is where the cycle gets really troublesome for patients. Their quality of life, every day they're thinking, something's getting missed, I'm going to bleed, this and that. So that's why I emphasize that if you can nip the early onset headaches and migraines in early on, you will prevent a lot of these other symptoms, including eye pain in most of the patients.
okay. No, that's really good to know. Thank you so much for that. And then someone else has asked a question. What would you suggest as a treatment for migraines where my scalp gets extremely sore with migraine?
Again, these are great questions, and that's why I love these webinars. Is again, if you look at all our data, all our research driven, whether it's cavernoma or other syndromes, the answer is we don't know, we don't think it's correlated, it's in your head, those type of things,
Yeah.
unfortunately. But I've seen enough patients. And for me, what has worked really well for patients who feel like their scalp is very sensitive, so even to the point that they're having a hard time brushing, their hair, or sometimes even laying down on a pillow, so they're struggling there. Nortriptyline, the migraine medicine that I
Mhm.
discussed, discussing it with your family doctor, because independent of the migraines or headaches or cavernoma patients with nerve pain, like diabetic nerve pain,
Okay.
they are on nortriptyline. So that's how we are able to use this medicine to calm the
Mhm.
nerves down. And in essence, in my opinion, the idea is, or the pathophysiology is, that whether the cavernomas directly or indirectly have just irritated the brain, and somehow we need to do something to calm the nerves down. Now, that doesn't necessarily mean there's an active bleeding going on. It just means that the cavernoma has made the brain unhappy. So sometimes just by adding yourself or putting yourself working with your local doctors on this medicine can help calm things down.
Okay. No, that's very helpful, actually. How do you have any thoughts or feelings about somebody who has cavernoma using acupuncture as a treatment?
That's a good question. Again, my answer will be based on some of my patients who are doing it. And then, when I ask them how is it going, there's mixed feeling. Like if you're thinking that the acupuncture is going to fix everything, I feel like it's not that magical. But I think if it's used in a multidisciplinary form where you're doing some exercises and physio and medications and you're doing acupuncture, I think those patients tend to do the best in the long term
Okay.
because they're attacking it from a multidisciplinary standpoint. Now, I would say that, as you know, the acupuncture, the science behind it is the needling kind of helping the microfibers in our skin that eventually transmit all the information that goes through the nerves to the brain. So I think the scalp sensitivity patients or patients who are having headaches that are more like, responding to lights or sunlights or those type of things.
Yeah.
Anecdotally, I've seen that those patients respond really well to acupuncture. But I think if nothing else is working, and I would say go get acupuncture, it's gonna get, resolve everything. I haven't seen that so far.
Oh, okay. Okay. That's good to know. That's really good to know. We actually get that question frequently.
Okay.
Um, so another person has asked, you mentioned gabapentin. Are you aware if gabapentin has also been used to treat cavernoma patients for menopausal symptoms?
I'm not aware of that.
Okay. Okay.
Maybe I'll have to read about it, but I
Yeah.
haven't.
Yeah.
I mean, I can understand that gabapentin is a central, brainstem inhibitor. So a lot of the times, whether it's pain or inhibiting any, uh, triggers that are triggered by the brainstem, we use it. But personally, I haven't read about it so far. So that's
Okay.
good
That's a
information for me.
Yeah, that's good. Good question. So one thing about with the seizures, you did such a great job of really kind of explaining seizures. Is there any type of situation in which a seizures will progress to worsened seizures, and at that time, would there be any kind of change in their treatment, like a surgery recommendation, just based on that change? Do you think?
Good point. Again, patients do. Some patients do end up having issues like that, where they are having a seizure. And based on where the cavernoma is, let's say they're on seizure medicine, but then that same cavernoma now oozed a little bit more a few years later.
Yeah.
So then that seizure will become more intractable, meaning, in spite of being on the medicines and increasing the dose, they will have more symptoms, more severe symptoms, more like longer duration of those symptoms. Uh, if that happens, then this full cycle of workup, which includes video EEG, the patients get admitted. Sometimes we end up tapering down their medicine to capture the seizures even more, to identify which of the cavernoma is the culprit. So that kind of does require specialized care, and meaning you have to go to a major hospital uh, to isolate that and identify the surgical uh, lesion. So that's kind of one question, identifying which lesion is causing it. And then the next question is, will just adding or increasing the dose is going to fix it? Or now do we need to talk about surgical excision or surgical removal of the lesion? So yes, the simple answer is that lesions can evolve based on how the cavernomas are oozing or leaking. And then treatment has to be escalated from 1 to 2 to 3 seizure medicines. And if those three aren't working, then sometimes fourth, along with the surgical planning.
Okay, great. Okay, great. So what are your thoughts of migraines that are caused by iron left over from previous bleeds or surgery? Can these migraines be treated, or is it the same kind of treatment as you kind of spoken about already?
Yeah, again, I would say it's a good question. I would say that over time, once the iron deposition from the oozing, the hemosiderin that we say on MRIs or brain imaging is depicting, once things settle down, the natural tendency of the brain is not to live with the headache just because of that scar tissue for the rest of our life moving forward. No, the brain is naturally built to accommodate and absorb that so that long term you're not having headaches. So typically, if that is happening, this means the headache management hasn't been done properly, uh, and uh, and that's what's required to be done. But if somebody had a bleed or an oozing, and it's been 3 years now, and the MRIs for 3 years have been stable, the rationale that that hemosiderin that got deposited is now going to trigger headaches for the rest of my life. I don't believe in that theory. I think that can be treated.
Okay. Okay. Good to know. So there's a couple of things that people are asking about, what are if these things are okay for cavernomas. One of them is hair dye. Any concerns about the use of hair dye with people with
No,
cavernomas?
there
Okay.
it's pretty plain safe.
Okay. What about red light therapy?
That's a good question. I've been asked about it. I have one patient who gets it,
Okay.
uh, and but otherwise we don't have a lot of information. We do know uh, that long term can have implications theoretically based on my reading. No studies, no research to answer it in a very specific way. But based on my understanding about it is long term, meaning, if it's a consistently long term thing over many months, I would personally suggest to avoid it until more data is available. But short term is okay, meaning, few sessions for 4 weeks, things like that.
Okay. Okay. Thank you so much for that. So, last question I'd like to give you, because it might be a little bit of a complicated answer, maybe, is we have a lot of people in our community who really talk about the use of CT versus the use of MRI. And we often see CT being used in the emergency room because it's quick, and on that sort of thing. And it's readily available. Can you see hemorrhages on CT when they're taking place and or MRI? And kind of if you can kind of sum that up a little bit on which one is best or when it's more appropriate for one or the other.
Great question and very timely. So just like I think 3 or 4 months ago, a new paper came out that looked at how the behavior, because the access of CT scan has become so easy all over the world, and patients, plus more so the physicians, have started getting CT scans so frequently.
Yeah.
The study showed that even in the age of 50 or 60, it's leading to more cancers later on in life. So this is the first paper that's kind of pushing a lot of us physicians now on the back foot saying, let's not do the CTs as much as we do. Like even in our stroke world, it's like bread and butter for us. Like every day we're ordering 16 CT scans, right, on different patients.
Yeah.
Uh, so this data that just came out was really helpful for us to know that, okay, our old school thinking that only, 20-year-old or 30-year-old we need to avoid, but as we get older, who cares, right? But no, we're seeing this, the impact on patients. So my personal, change in after this study is that we should not jump onto the CT just for that sole reason, because cavernoma patients tend to go to the ED more frequently for different symptoms. So they get exposed to CT scans so much more. So I think my personal experience also tells me that unless the symptom is really dangerous, nobody does anything dramatically, unlike aneurysms or all the other types of strokes or bleeds that we deal with. In cavernoma patients, as you know, even the treatment is subacute to chronic. That allows us to buy time to get MRI, which has no radiation exposure in that regard. So that's more of a personal, approach that I would suggest we should based on this recent data. But to answer your question about bleed, any acute bleed, which is significant, CT scan is great at picking it up.
Okay.
So if a cavernoma has misbehaved, meaning it has leaked and oozed and there is bleeding, then the CT scan normally picks it up. Now, if it has oozed a little bit, it will get missed.
Okay.
And that's where the confusion starts, that the patient is confident that I have something going on here, and they get the CT and the CT is normal. Those are the patients where every time we get the MRI a week or 2 weeks later, it confirms that yes, there was a little bit of oozing there. Now, does it change the management? As you know, not really, but it does give some relief and vindication to our patients that, there is something going on. I'm not like making it up. There's something getting affected. And I think my approach would be in that case, MRI is higher yield anyways. That would be the way to go. But anything that's dangerous, significant, bad headache with a new focal weakness, CT scan gives that data, and only in those situations we should leverage CT scan.
Oh yeah, that's great information, really great information. I think along with the information you talked about earlier about when you should be seeking, urgent emergency care with what type of symptoms together helps to know patients when they know when they should go to get that looked at more thoroughly. And also the validation of patients is so incredibly important when they're experiencing symptoms, and
100%.
it's very
Yeah.
valuable. Well, really thankful you're able to be with us today, Dr. Zafar. It's been really wonderful to hear your expertise and your knowledge and your thoughts on things. And thank you so much. And for everybody who's attending, thank you for being present and all your wonderful questions. And many of you submitted questions ahead of time, which was really helpful as well. And this webinar will be posted probably in about 3 weeks' time, and you'll get the link. And if anyone's interested in the study that was done recently that Dr. Zafar just referenced, please let us know, or we'll make it available in our newsletter. Okay. Thank you, everyone, and thank you, Dr. Zafar, again. Really
Thank you so
appreciate you
much.
being here.
Bye-bye.
Take care.